Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts.
Hi, my name is Manesh Patel, and I'm joined by friend and colleague Mike Gibson as we talk today about understanding residual stroke risk and the consequences of undertreatment. Thanks for joining me, Mike.
Well, thanks for having me again, Manesh. Always a pleasure being on with you.
Yeah. Well, Mike, when we think about understanding residual risk for stroke and the consequences of undertreatment, I think there are two parts. Like, what does residual risk really mean? And residual risk is important for us to think about. It's the potential risk for things that might happen after all the possible measures or treatments have been done to reduce and eliminate the risk that people have for a condition. Now, I'll just say residual risk is something that's important, but I'll tell you in practice, that's still a high bar. We know that there's many patients and many people or practices where it's really hard to do everything one can imagine to reduce the risk of an event, whether it's managing your blood pressure, your diabetes, your cholesterol, and then getting on to figuring out how we anticoagulate you for atrial fibrillation and manage your heart failure, et cetera. But it's interesting that even then, there are still very number of people that when we do those things, there's an opportunity to go from their initial risk to their residual risk. And understanding this residual stroke risk in people with atrial fibrillation is important because it gives us a sense of what's the continual threat or unmet need for this person who's not responding or not able to get to where we want them to be for their health. And so that, in a sense, is the concept that we want to at least have a conversation about today. Now, when we think about atrial fibrillation and stroke, what is the residual risk of stroke? So the definition, as I said, is the residual risk of stroke refers to that ongoing risk of stroke in patients who are already receiving guideline-directed anticoagulation therapy. One could also expect or hope that they're also getting guideline-directed therapy for their other underlying conditions, whether it's high blood pressure, their heart failure, or diabetes. We know that some of those things interplay to reduce risk too, but when we think about it for stroke reduction in patients with atrial fibrillation, one way to think about it in a population way is all the people getting their usual therapy plus anticoagulation, what matters. And why this matters is patients may still appear protected. They're, remember, taking on, I'll call it the safety issues of anticoagulation. So they're taking on a burden of a possible risk for bleeding, and they may be protected for stroke, but then they may still have stroke events, which may reflect subclinical AFib, inadequate dosing, comorbidities, or limited efficacy at the current ages. And so just going through residual risk by the numbers, which is often an important feature as we think about this, recurrent strokes make up almost 25% of the 800,000 strokes that occur annually in the United States. So just thinking through that, a quarter of all the strokes that happen are recurrent strokes. So that just tells us our current strategies for managing and caring for patients with atrial fibrillation or stroke prevention in general is not sufficient. And 50% of these patients post-stroke or TIA face increased risk within a few days to weeks after this event. And so that only tells us, again, that not only is the residual risk high, it's high often at the time of these events. And the highest happens to be within the first 7 days after the initial event. And patients with TIAs, sort of these warning events, have a 10-year stroke risk of 19% and a 43% combined 10-year stroke risk. So again, high risk individuals. And these recurrent strokes are linked to longer hospital stays, poorer function, and higher mortality, as one might imagine. And so we've seen that even in the current era with DOAC use, direct oral anticoagulants over the last 10 to 15 years, residual stroke risk can range from 1.3 to 2.5% per year, depending on the CHADS-VASc score and other factors. And some of those other factors will, of course, identify things that you see in your practice: non-adherence, underdosing, and treatment gaps. They're major, I'll call it, contributors. And some examples include that even in well-managed populations with DOACs, 1.3% have stroke. And that's across from the clinical trials where we might imagine those are some of the highest quality ways of evaluating people because they're a little bit, they're obviously done in the real world, but they're a little synthetic because they're in randomized trials where everything is being monitored. And even in trials like Aristotle, where apixaban was used, the residual risk or the rate of stroke in the treated arm was around 1.3%, and that's pretty significant. We also know that underdosing of DOACs leads to a stroke risk. In the Garfield real-world registry, or in Orbit or Pinnacle, when you sort of combine all those, it approaches about 2% per year for people that are underdosed. Patients that are not adherent, they're unable to take it all the time, they're missing doses within 30 days, their baseline risk can go up to 2.5%. And then those that are untreated and high risk, their risk of stroke can go up to 4.5% per 100 patient years. Again, a real risk that keeps continuing for our patients. And what are the factors, the risk factors for stroke, as we've talked about it? Well, like a lot of things in life, they're tied to all the things we're exposed to and all of those underlying things that those exposures lead to. Some of it, of course, is linked to also just our underlying genetics and genomics, but most of this is the environmental effects of having certain types of exposures or environmental disease processes. Those include poor diet and nutrition, physical inactivity, hyperlipidemia. We see a higher rate of risk of stroke in Black and African American patients, increased obesity, hypertension, diabetes, tobacco, sleep apnea, and the female sex all have a higher risk for stroke, as has been described in many of the risk factors conversations we have, but also in some of the stroke scores we have. And that residual risk is despite oral anticoagulation in patients with atrial fibrillation. And maybe the highest residual risk factor in those patients is a prior stroke or TIA. Again, often because these patients have been on therapy and are failing it. So those are patients who are identifying themselves as that current therapies aren't working and they're continuing to have events. But there are other factors of importance like permanent atrial fibrillation, prior MI, EGFR less than 70, increasing age, COPD, and hypertension, again, because those are constant, common things that drive residual risk, but also risk that continues. So I guess a question for you, Mike, is that given what we've seen about persistent and residual risk, even with DOAC therapy, how are you navigating conversations with patients who've had a prior stroke or TA but remain reluctant to resume or escalate anticoagulation?
Well, you showed it on your slide, Manesh. Having had a prior stroke or TIA is a correlate of being at risk for another one. So, boy, I think, if you've had a TIA, you kind of dodged a bullet, and better to put that seatbelt on and get some protection before another one comes along. In one of the trials that you were involved with, I was very cheered to see in the Pacific program that when you lump together stroke and TIA, that was reduced with these drugs. So it's not just trying to prevent stroke, but also TIA. I think we have to keep that in mind. But one of the problems is hemorrhagic stroke, and people are very hesitant after hemorrhagic stroke to resume anticoagulation. I was asked to speak about this at ESC a year or two ago, and there are ongoing trials looking at this, very hard to study, but I think it's a conversation you have to have with the patient with a bleeding stroke. Do you want to go back on? But there is some compelling data suggesting overall, that might be a good idea, depending upon the nature, size, and damage from that bleeding stroke. So, it's a complicated conversation, but one we need to have more often.
Yeah, I think for sure it's an important conversation and one that we have to have more often, but there are many moving sort of features, as you've highlighted, that individualize what we think for our patients. Well, as we have that conversation, often what we think about are some of the gaps in therapy. Even if we've got people that we're treating and they have a high residual stroke, one of the things I often say is, are there things that we're not doing with our DOAC-treated patients or other anticoagulant-treated patients that continue to raise their stroke risk? And I would say the gaps exist in that some patients are not getting therapy. Some of the risks and registries have highlighted that maybe up to 50-60% of patients are getting therapy, but 40-50% of patients who meet criteria are not prescribed a DOAC. And it's discordant in what they receive. There's underdosing that's very common. Up to 25% of people in some registries are underdosed, meaning that the doctor or the patient's concerned and that together they've come to a lower than what would have been planned dose, whether it's the risk factors, renal function, or something else that's driving it. A variety of those things mean that, as we've highlighted, the stroke risk in our population in the United States and worldwide remains high, and it's a leading cause of death, and it's unacceptably high, because if you think about how much that's growing compared to other things we've really made a dent in cardiovascular medicine, this is one of those beachheads where I think we have a huge opportunity to affect human health. So what are the factors affecting anticoagulation prescribing and adherence? I'll sort of break it down into three that people often talk about. The first is provider inertia and lack of awareness. And that's part of why we're having this conversation and others, which is, we understand that we've probably by now had lots of conversations for people about stroke prevention and thinking about atrial fibrillation. But people still think about, well, it's a low burden and we're successfully keeping them out most of the time. There's a low perceived risk. The patient's factors such as frailty or age or CKD or substance use or aspirin use may make people feel uncomfortable using it, or just plainly the patient refuses it because of their fear of bleeding or other issues. So that inertia or lack of awareness of the risk plays a large part, might be the first one. Cost and access. Anytime we think about any therapy, we have to think about the cost and access of that therapy. And certainly a lot of these have now gotten much more affordable than when they first came out, but I think that's an opportunity. Still should be available to many, and I think it's a feature, but it's not, I don't think, the predominant feature, because these are quite prevalent in our practices now. The last might be just the complexity of our healthcare system. This is only growing, unfortunately, not reducing. So getting the information to the patients might have their own concern with fear of bleeding, not able to have conversations with people when they have bruising or minor bleeds, making decisions because they're not interacting with people, or having their treatment decisions influenced by all the things, Mike, that you and I talk about, which is just, I'll call it the fire hose of information that people now get through a variety of sources, whether it's social media, news, stories, family, friends, the things that fire up their emotions and strike a chord, which may or may not be linked to the actual science and information about the disease entity that might make them fearful. And lastly, a lack of knowledge. What is the efficacy and safety of some of these, and what are the trade-offs? I mean, it's a lot for us to learn, much less to share with our patients. And so obviously these things affect the therapy. So often what we try to do when we're talking to our colleagues about this is to go over those things. What's the common causes of undertreatment? People are still fearful of bleeding, but they also want to refuse it or use the incorrect dose because they're concerned about that bleeding risk. What's the role of adherence and persistence? Well, 1 in 3 patients have poor adherence, and 27% may miss a dose within 30 days of the therapy annually. And so there's still not just undertreatment, but adherence and persistence is hard with a gap. Sometimes a 15-day gap in DOAC therapy can increase the stroke risk by 30 to 40%. And then non-major bleeds, as you highlighted, I think in some of our talks, that no bleed feels minor, and so when someone has a bleed, they don't feel like, oh, that's a minor bruise, or that's that large brown spot on my leg. It feels minor as it's healing and from yellow to purple. I think people feel like those bleeds are significant. And any of these bleeds, nosebleeds, et cetera, cause them concern, and they can often lead to pausing of therapy and reducing the therapy. And 7% of these patients in some registries have stopped therapy without ever talking to their clinician. Just, again, this is unacceptable. I'm not sure I want to continue on with this. And, insights from the ACC Pinnacle Registry have highlighted that this anticoagulation underuse in the older population with atrial fibrillation is a big driver as you go across the CHADS-VASc score, or the CHADS score, which was used in the original clinical trials, goes from 0 to 6, and the CHADS-VASc score goes from 0 to 8. You see that the no thrombotic therapy actually can go up as some of these numbers go up. What I find interesting is that there's a risk treatment paradox. Often we see that the highest risk patients often are equal in getting the least risk of they're the least likely to get therapy, even though they have the most benefit possibility. Again, here, because we're benefit and risk balancing, almost like the balance beam we've talked about, where the highest risk patients are also highest risk for bleeding, and people are really uncomfortable sometimes using an anticoagulation. And oral anticoagulant therapy has increased with higher CHADS and CHADS-2 scores, but less than 50% in this ACC Pinnacle Registry of the high-risk patients received an oral anticoagulant prescription, as I sort of talked about this paradox that exists in many therapies. And then there's an ongoing gap in care with suboptimal dosing. As I've highlighted that some of these therapies, including some of the most common ones used. If you said, that the market leaders, at least for atrial fibrillation, for a long time have been apixaban and rivaroxaban. There's been significant dose reduction, especially with the apixaban, where 2 out of the 3 categories are needed, and people might have one category of age, body weight, or a creatinine of 1.5, and people might use one of those to dose reduce, sometimes up to 20% of those people have a dose reduction, or 13 or 15% with the rivaroxaban or apixaban have a dose that's not even recommended, a different dose altogether. So just worth thinking about when you're using this. I often say that, there's a lot of PK/PD we learn in medical school, but the evidence-based dosing is what you need to use in clinical care, and not to try to draw your own curves in practice to try to understand that. I wish we get there soon with our patients, but generally we know that the evidence is based on those dosing curves that we've seen in trials with outcomes associated with those doses. So suboptimal dosing still plays quite a big role, with ongoing gaps in care with that suboptimal dosing. So it's not just that you have suboptimal dosing, but underdosing of patients with atrial fibrillation and with DOACs is associated with a significantly higher mortality and stroke risk in all of the registries we've seen. And I've sort of highlighted the clinical importance of that, in that it's likely that those patients that you're looking to dose reduce, you're also clinically identifying some of the highest risk patients. So if you're looking to really treat them, it's not worth dose reducing them so they don't get the stroke benefit, but they still get the bleeding hazard. It's valuable to at least make sure those individuals get the benefit of stroke reduction. And so some of these individuals actually have higher all-cause mortality with non-recommended low dosing. And so it's worth noting that these individuals are not benefiting, at least observationally, from your practice of underdosing people. And these ongoing gaps in real-world adherence and persistence to DOACs and atrial fibrillation continue, across a lot of these therapies. We see adherence is suboptimal, with 1 in 3 patients not adhering to their DOAC therapy, and persistent drops over time, 25% of patients discontinuing therapy within 6 months. If you just think about that for any new class of therapy, we should be looking for other things that can help us if a quarter of our patients who are at risk for stroke can't continue after 6 months. And these barriers for oral anticoagulants in atrial fibrillation are, as we've highlighted, physician and patient concerns, their risk for stroke, major bleeding, low burden, some of the common things we hear and talk about. And their fear of bleeding fuels this underuse of dosing, or underdosing and underuse of anticoagulants. And we've seen both clinical trials and other features shown this. Jeff Weitz, one of our colleagues, has outlined, he said, we still have an unmet need for safer anticoagulants because there's an increased uptake of anticoagulant therapy that will increase the uptake of anticoagulant therapy in our patients with atrial fibrillation. Jeff and others like ourselves have said generally that we have a large number of patients that don't get treatment for these reasons, as we've highlighted. So the key takeaways and I guess conclusions from our conversation here has been that there's a residual risk of stroke, and the consequences of undertreatment are real. And the residual risk is often the risk defined by the people that are on anticoagulation that still have events and that remain vulnerable. And we've quantified that risk anywhere but up from 1.3% to 2.5% to 4% for patients not getting therapy, and patients at high risk for stroke with atrial fibrillation. These treatment gaps persist because of undertreatment, underdosing. And addressing this requires action, optimizing guidelines, identifying candidates, and then thinking about hopefully new therapeutic options like the Factor XIa inhibitors to close the gap, or other things that can go down that pathway. So I'll end by asking a question of you, Mike. As we prepare for clinical trial evidence, how do you reconcile bleeding risk and efficacy when evaluating the strategy most appropriate for your patients?
Well, Manesh, I think we've talked about this in other episodes. We need to do a better job of getting the patient's thoughts, having a shared decision-making conversation with them. Different patients will value bleeding or an ischemic event differently. So let's back up a little bit. What do we do in practice? We see a patient every 3 months, 6 months, and we look to say, are you tolerating this medicine? Are you bleeding? Have you passed your bleeding stress test? If you have passed your bleeding stress test, your risk of bleeding in the future is less. So we like to think of risk assessment as this one-time thing. No, risk assessment is an ongoing issue, and we need to iteratively assess risk. Number one. Number two, patients don't care about the population results. The patient cares about what's my risk. And so we need to use AI and more advanced tools to give an individual risk to that patient. And thirdly, we need to take into account, what do you want to prevent? Do you want to prevent an ischemic stroke? Are you worried about a stomach bleed? So we need to incorporate their ranking of all of these outcomes. And finally, you mentioned it in your talk, Manesh, we study PK/PD in medical school, but we don't really integrate that into our practice, or we shouldn't. But what if we had AI, and we've done this, where we take the PK/PD from, 8,000 patients, along with their age and gender and prior stroke and everything else, and make recommendations. So we have developed a tool that I'll be presenting, hopefully as a late breaker here pretty soon, where we do integrate all these things. Patient-specific risk, iteratively assessed over time. At any moment in time, you can predict the future risk, taking into account what the patient values in terms of minimizing the different side effects and ischemic risk. And finally, modeled and based in some of the science of PK/PD, but also the clinical outcomes. So I look forward to a world where we use and harness some of the more advanced decision-making tools we now have to engage in shared decision-making patients in a way that they can optimize their preferred outcomes.
Yeah, Mike, it's really exciting as you talk about it, because I do think as I make the comment about what our brain can manage versus what all the inputs will be as we get other advanced tools. We all know that there's going to have to be therapeutic ability to personalize care, and especially in cardiovascular care. So there's a huge opportunity there. Pretty exciting to go forward with that. So
has bled is the score we use, but Manesh, I always say it tells you if it has bled, but not if you will bleed.
Yeah, that's right.
You need better bleeding risk assessment tools, and we need to iteratively assess it over time. It changes over time.
Yeah, no, I was just thinking about the future that comes with us as both we have new therapeutic options and new ways to apply those options to our patients. There's a great opportunity using much of the information that not often is used for our patients. So hopefully our audience here has appreciated that there's still a large unmet need of patients not getting optimal therapy that have residual risk. And we're going to have a lot of possible options to think about that in the upcoming future, both integrating all the data and having new therapies come to light.
We hope you found this podcast useful and educational.